So I'm Annemieke Aartsma-Rus. I work at the Leiden University Medical Center and I'm a geneticist. And what I will talk about today is why genetic diagnosis is important for Duchenne. And I will also give you some, that one does work. I will also give you some background. So an introduction into basic genetics, explanation of how Duchenne is inherited, what different type of mutations there are, how we can detect them, and also finally why it is important to detect these mutations in patients but also in parents. So first, some basic genetics. So we all contain or consist mostly of proteins. And we make these proteins ourselves. And we can do that because we have genes. And the genes contain the blueprint for these proteins. Well, these genes are located on our chromosomes. And all of us have 46 chromosomes. And they come in pairs, so we have 23 pairs, where from each chromosome we get 23 from our father and 23 from our mother. 22 of the pairs are identical, and the exception is the sex chromosomes. And here we have an X chromosome and a Y chromosome. And probably you know that women have 2 X chromosomes and men have 1 X and 1 Y. And here's a picture of the chromosomes, just so you can see that indeed, so this is from a man because there is a Y chromosome there. You can see that we have these different chromosomes. They're not all of the same size. We have small chromosomes, we have large chromosomes, but they come in pairs. And the one in the bottom right, for you right, the X chromosome, females have 2 of those and don't have the Y chromosome. So it's good to understand that in each of our cells we have all the genetic information. So we have these 46 chromosomes. The exception is the germ cells. So our eggs and our sperm cells, here we have only 1 copy. And that is because when we get conception, the germ cells and the egg cells merge. So you need only half. So a father will give 1 copy of each chromosome and an X or a Y, and the mother will give 1 copy of each chromosome and 1 of the X's. And then when these cells merge, you have, again, the pairs of chromosomes. And it's interesting to see that the men decide the gender of the child, because the women can only give an X. The men give either an X or a Y. So it's the men, or the men germ cells that decide the gender of the child. So now, from gene to protein, so the genes contain the blueprint of the proteins, and this we call the genetic code. And the genetic code is located or dispersed over each gene in exons, and we'll get back to exons later. But what the cells do is they translate the genetic code into protein. And the way this happens, so each cell has all the different chromosomes, all the different genes, and we have 23,000 genes. Each cell has them. However, which protein you make depends on the tissue. So in the liver, there's a lot of enzymes made that detoxify, for instance, alcohol or other toxins that you might ingest. These enzymes are only made in the liver, not in other cells. Dystrophin is a protein that's made primarily in muscle and brain. And dystrophin is an extremely complicated protein. So it's more than 4,000 amino acids, the building blocks, more than 4,000 building blocks long. And just to illustrate or use an example, I use this. So actually what the cell does is like Lego. It builds proteins out of little pieces, the amino acids. And genes come in all shapes and forms, and the dystrophin is one of the most complicated ones. So I use this one. The Death Star, I think, is the most complicated Lego structure that you can build. The manual is over 50 pages long. The dystrophin gene is the longest gene that we have in our genome, so I thought that was a fitting comparison. And then you can see all the different things that go into it, all the different amino acids. And if you follow the gene, if you follow the blueprint, in the end, you end up with the final product, the dystrophin, or your Lego Death Star. And just to understand, so I think I understood that it takes days, or if not weeks, to build this. The dystrophin gene, it takes also hours, more than 16 hours to build it. So just understand that this is not a simple thing. Many things in cells happen in seconds. The dystrophin is an exception. It takes a long time. So then talking about mutations. So genes have a specific function. If you have a mutation in a gene, that means that that gene cannot do its function anymore. And what happens then depends on what the function was of the protein, but also on where it had a function. So if you have a problem in the enzyme that breaks down alcohol, what you will have a problem if you drink alcohol. And there's people that actually don't have this enzyme. If they drink alcohol, they get into a coma. So this then has that problem. If you have no dystrophin, dystrophin has a function in muscle and in brain, and that means that if you don't have functional dystrophin, you will have problems in the muscle and the brain. You will not have problems, for instance, in your kidney or in your liver, because dystrophin does not have a function there. Now, what does dystrophin do? Well, I will not go into what dystrophin does in brain, and that is because we did not really know what it does in brain. It has a function because we know that Duchenne patients can have behavioral issues, there's a higher incidence of ADHD or of OCD, of epilepsy, so it does something, but we don't know what exactly. What we do know is what it does in muscle. And what it does in muscle is comparable to a carabiner. So this you use if you go mountain climbing. You link one part to your harness and you link the other part to the rope. Now you don't need this to go climbing, and this is similar to dystrophin. You don't need dystrophin to make muscles or to use muscles. However, you need this as a safety precaution. So if you're climbing, and it all goes well, you don't need this safety precaution. However, if you fall and you're not linked up to the rope, then you will crash. But something similar happens with dystrophin. Dystrophin protects muscle fibers against damage when you use your muscle. And when we use our muscle, there's a lot of potential for damage because there's quite a lot of force that's applied to the different muscles fibers. So without this protection, without dystrophin, there's damage all the time when we use our muscle. So this is the function of dystrophin. It protects muscle from damage. And that means that if you use your muscle, it will be damaged if you don't have dystrophin. And then you can think, well, maybe then Duchenne patients shouldn't use their muscles. But the problem is, we all know, if you don't use your muscle, you will also lose your muscle. So it's a bit of a catch-22. If they don't exercise, they will lose their muscle. If they do exercise, they will also lose their muscle. And that's, of course, the very sad reality of Duchenne. So we talked about mutations. And it's very good to understand that whether these mutations are a problem depends on when and where they occur. So as we sit here, we have billions of cells, and it's very much possible that there is a dystrophin mutation in one of these cells. However, that doesn't matter. If it's a mutation in liver or kidney, we don't need dystrophin there, so that's not gonna matter. It might even happen in one of our muscle cells. Still doesn't matter, because we have tons of other muscle cells that do make dystrophin. So it's not so much of a problem if we have a mutation in one cell of the body for dystrophin. There's of course other things where it does make a problem. For instance, if you have a protein that normally prevents the cells from growing and you have a mutation, then that cell will start growing, and that is what leads to cancer. However, for dystrophin, having this in one cell does not matter that much. It can also occur during embryonic development. And of course, as an embryo, you start as a one-cell system, and then you become 2, then you become 4, then you become 8. If you get a dystrophin mutation in a 2-cell stadium, that means that half of the cells will not have dystrophin, because half of the cells will derive from one of these 2 cells. And that is what we call mosaicism. So then half of the cells can make dystrophin and half of the cells cannot make dystrophin. Well, that is still generally not so much of a problem. We can live with 50% dystrophin. What is a problem is if there is a mutation in the germ cells. So if the X chromosome of the father or the mother germ cell, so egg or sperm, if there's a mutation there, and that cell is then given to the child, that means that none of the cells of that child can then produce dystrophin. And then we need to go back again to the fact that the dystrophin gene is located on the X chromosome. And we already learned that women have 2 X chromosomes, men have only 1. So if you give your mutated X chromosome to a male child, there will be no backup, and that child will develop Duchenne. If you give it to a female child, she will have a backup copy, so she will be a carrier. And then, of course, if she gives that X chromosome to her child, that's the son, he will have Duchenne. So this is how these mutations arise. So often, I know that some carrier females feel guilty because they give the mutation to their child. Well, of course, I mean, we just heard, these are the arguments that you know you shouldn't, you rationally know that you, of course, didn't intentionally give that mutation to your child. But still, there can be these feelings of guilt. But it's good to know that you might as well have received this from your father or your mother. It's not necessarily you that made this mutation. So then, talking about inheritance, and then we went over this, but I'll just illustrate it again. So we have a man with a normal X chromosome in blue and his Y chromosome, and then we have a female carrier. So a woman that has 1 normal X chromosome in blue and 1 X chromosome where there's a mutation in the dystrophin gene, and that one is red. Now, when we look at the sons, what we know, the sons always get from their father a Y chromosome. So the small little thing, the blue little thing. The sons from the mother get an X chromosome, and this can be either the X chromosome that's normal, the blue one, but it can also be the X chromosome with the mutation, and that will then lead to a boy with Duchenne. For the women always will get from the father the X chromosome, so that is the healthy copy that they will always have. From their mother, they will get either the healthy X chromosome, the blue one, or the red X chromosome, the one with the mutation, and then, of course, the daughter becomes also a carrier. So this is basic genetics. So then, what we can do, let's see whether we've understood this. So this is a family tree. All the squares are the males, the circles are the females, or the man and the woman, and all the squares that are black are Duchenne patients. And if we see this, and this is how genetics was done, say, 30, 40 years ago, when we didn't have all the fancy diagnostic tools that we have now. And if we look at this, so what we can see is that if we go all the way up to the grandparents, that mother is probably a carrier because she has a son with Duchenne. But then if we go all the way to the left, to this group here, well, this man has no Duchenne. And of course, he couldn't have Duchenne because he gets his, he could have Duchenne, but he didn't. He got the right X chromosome from his mother. Then, of course, all these children have no risk of developing Duchenne because they get the healthy X chromosome from their father. And this woman is not related, so she may be a carrier, but the chance of that is very small. Now, looking at this, because this woman has a son with Duchenne, she must be a carrier, because also she has a brother with Duchenne. Now, the same here. This woman has a son with Duchenne, so she must be a carrier. She also has a healthy son, but I mean, this is possible. There's 50% chance of giving the mutated X chromosome or the healthy chromosome. Now, if we look all the way here, we see, so this woman has a healthy son and a healthy daughter. But that doesn't mean that she's not a carrier. She can still be a carrier. It's just that then, luckily, she gave the good X chromosome to her children. She can still be a carrier, and that means that her daughter also still can be a carrier. And currently, with genetic diagnosis, we can figure out, well, is indeed this person a carrier or not? And then we know for sure. But before, when we did not have these tools, what was needed was statistical tests, like there's so much % chance that you are a carrier and so much % chance that you are not a carrier. Fortunately, we do better now. So I mentioned these germline mutations, the mutations that happen in the sperm cells or the egg cells. And this has consequences. So if you get sperm cells that have a mutated X, this is a problem if it's inherited by the daughter, because he will become a carrier. For the son, this will not be a problem, because the son does not inherit the X chromosome from his father. So that will not be a problem. For women, it's a problem for both, can be a problem for both the son and the daughter, because the daughter becomes a carrier and the son can have Duchenne. What is known is that, this means, if it happens in a germ cell, if the mutation occurs in the germ cell, what will happen is the son can have Duchenne, you test the mother and she is not a carrier. So then you know the mutation must have happened in her germ cells, it must be new. That doesn't mean that it happened in one germ cell. Often it will happen in a percentage of germ cell. And unfortunately, the percentage in which this happens varies per individual. So it can be anywhere between 5 and 20%. And the frequency you don't know. I mean, you would have to isolate all the X cells and analyze them, but that of course is not realistic. But that does mean that even if the mother is not a carrier, and she has a son with Duchenne, there is a risk that she can have a second son also with Duchenne. And I think this is important to know and to realize. So then we're going deeper into the different mutations that can cause Duchenne. So I mentioned already the genetic code is dispersed over exons, and dystrophin is a large gene. It has 79 exons that are located far apart over the gene, but all these little building blocks fit together like a puzzle and then can be translated by the cell into dystrophin. Now, what can happen in Duchenne? Most often, patients will have a deletion or a duplication of one or more exons. So if we go back to our example, most patients, they will have, for instance, they will not have exon 45. Or they will have it twice. And what you can see is, well, if you don't have this exon, 44 doesn't fit to 46. So what we say is the genetic code is disrupted. And there's also other mutations that are small mutations, which are small, and I will go into detail in small mutations in a future slide. These mutations can all lead to both Duchenne and Becker. And I'll first explain the difference in the protein, on protein level, and then I'll explain the genetic background of this. So we saw this carabiner thing. What happens in Duchenne is that only the first part of the protein is made. So you have your carabiner, you link it to your harness, but the part that links to the rope is gone. So it's not very helpful because you're not connected. So if you drop, you crash. So this is what happens in Duchenne. What happens in Becker is that you have the both important domain. You can click to your harness, you can click to the rope, only the bit connecting it is shorter, which means that if you fall, the elastic part is short, so probably it's not going to be a very comfortable fall. And you may even strain something, but compared to dropping 400 feet, it's of course preferable. And these are the different types of proteins that we find in Duchenne and Becker. Now, how does this work? Well, this works because I already explained in Duchenne patients, mostly the genetic code is disrupted. So here again, we see a deletion, 48, 49, 50 are missing, and we see 47 doesn't fit to 51. And we say then the genetic code is disrupted. The code becomes unreadable. And the code becoming unreadable means that instead of these Death Star Lego parts that you normally should put in, suddenly this is all replaced with My Little Pony Magic Castle building blocks. You cannot build the Death Star with these different building blocks. And this is what happens when the genetic code is disrupted. Instead of the normal building blocks, suddenly the code says, use other building blocks. You cannot get a functional protein if you use the wrong building block. So this dystrophin is not functional. Now, with Becker, the genetic code is maintained. So you see 47 and 52 fit. So here, actually more is missing. 48, 49, 50, and 51 are missing. But the genetic code is maintained. These two exons fit together. And if you again use the Death Star, this means you've ripped out 2 pages of the 50-plus page instruction manual, you will miss part of it. You may have one compartment that's not built, but the general construction of the thing will still be there. And the code remains readable, you just miss a little bit. And this is what leads to the shorter protein. So then we have the small mutations that I already mentioned. So these come in two types, and we start with the bottom one because that is very similar to what happens if you have a deletion or a duplication. So you have a small mutation, an exon 35 that normally has a certain shape now becomes a different shape. And that disrupts the genetic code. So you see the code is readable until 35, and then from 36 it becomes unreadable, which is indicated by all these little asterisks. So again, this is the same situation where your Death Star parts are replaced by My Little Pony or whatever, but not the Death Star. There's another type of mutation, and this happens in about 10 to 15% of patients. And here it's important to know that genes have a start signal that tell the cell, here you need to start translating. I mean, genes are big, they need to know where to start the translation. And then at the end it has a signal that says, the protein is done, this is where you can stop. And these signals are embedded in the genetic code. Now there are mutations, small mutations, that can change the code from an amino acid, for instance, for one part of the Death Star, one of those little Lego blocks, into the code that says, stop, the protein is complete. Now, if that happens in exon 35, again, what happens is that you start building, and then halfway through, on page 13 out of 40 of your Death Star manual, you think, it's done, it's complete. It says here that this is the last step, I can stop building. Even though, actually, it's not complete yet. There's a lot more. There's a lot more pages that tell you what to do. But since the instruction manual says, stop, it's here, this is the end, that is what the cell will do. So it will do the same thing as what happens when the genetic code is disrupted. You get only the first part of the protein. But here, the genetic code is not disrupted. So it's all present, it's just not used. So how do we detect these mutations? Well, probably in the near future, what we will do is just analyze all the DNA, the whole genome, all the different genes, all the different chromosomes, just not looking only for Duchenne, but looking for all different muscle diseases. If a patient presents with muscle problems, we will look for everything. However, at the moment, that is still too expensive. So what we do now, and what's also in the guideline, is that step one, we check for large deletions and duplications. And we do that first because these are quite common. So 70% of patients have these large deletions or duplications, and it's easy to check for them. So what you can check is for each exon, is it present or is it absent? And if it's present, is there one copy or are there two copies? Or in women, are there two copies or are there three copies? Or is there one copy? So this test works for both patients and carriers. Now, if in 70% of cases you will find the deletion or the duplication, then you check the genetic code. So would we expect here that this is Duchenne, so the genetic code is disrupted, or would we expect Becker, the genetic code is maintained? Now this is not always clear cut. So it's possible that the genetic code says this should be Becker, but actually the patient has symptoms when he is 2 years old, typical Duchenne symptoms. Then what is more important is the clinical presentation. So you then, even though you would expect Becker, you see the patients as a clinician and you say, well, this is typical Duchenne, so that is leading. However, if it's not that clear, or for instance, a patient is accidentally found. So there's a patient who has elevated creatine kinase, a muscle damage marker, when he goes to the ER for something unrelated. And that starts the whole diagnostic process. And then you find the mutation where you see this before symptoms, then it can be helpful to know, okay, this is likely going to be Duchenne or likely Becker. But what's important to know is that genetic is not, so the genes don't determine whether someone has Duchenne or Becker. the clinical presentation. So the symptoms, the age of onset, that determines whether someone has Duchenne or Becker. And the genetic part, in 90% of cases, fits with that. Well, if you don't find a deletion or a duplication, you go to step 2. You check for the small mutations. And you don't do that immediately because it's expensive and labor intensive. Because for each of these small puzzle pieces, you have to look one by one whether there is a mutation there or not. And that takes time and therefore is expensive. Mostly, so in 99.9% of the cases, you will find a mutation either at step 1 or step 2. Only when you don't, and the clinical presentation really suggests, well, this is a boy, he's 2 years old, the symptoms fit Duchenne perfectly. This really looks like Duchenne. Then you can take a biopsy and see whether dystrophin is present or not. Because if dystrophin is not there, that means that the boy has Duchenne. If it is there, it means that even though it looks a lot like Duchenne, there's probably another thing happening. There must be another muscle disease ongoing. What's changed in the guidelines is that previously a biopsy was often done after step 1. So if you couldn't find the large deletions or duplications, you did a biopsy, and then when dystrophin was absent, then you went to check for the small mutation, which was labor intensive and expensive, more so than taking a biopsy. However, of course, a biopsy is invasive, it's painful, especially, you don't want to do this in children if you don't have to. So now they changed. And also the techniques have improved. So first look for small mutations, and only in the very few cases where you don't find it, take a biopsy. So I think this is what I just said. Often you do not need a biopsy for a genetic diagnosis. There are exceptions when you don't find any mutation in step 1 or 2. And then if you don't find dystrophin, you know it's Duchenne. If you find dystrophin of an altered site, you know it's Becker. But there's another example, or another exception, and that is when you have a mutation where you think, well, but we've had, for instance, the exon 48 to 50 deletion that I just showed. That's quite a common deletion, and we find it almost always in Duchenne patients. Now you find it in the Becker patients. Well, this is strange, so something else must be going on. So then you can take a biopsy to see whether that patient indeed makes dystrophin or not. But also the other way around. If you have a mutation where you expect Becker, but you see Duchenne, you can use the biopsy to confirm that this patient indeed does not make dystrophin. The thing is that this will not change the clinical symptoms of the patients. It will maybe confirm the prognosis or help you, but it's not going to change anything. So it's some people, some parents really want it. So they have confirmation, my son indeed doesn't make dystrophin, or he indeed does make dystrophin, so I have some more certainty about the prognosis. But it's up to the patients, up to the parents to do this, because it's not going to change the prognosis, it's not going to change how the disease progresses. So finally, why is this important? Well, the first thing is that if you know the mutation, you can do genetic counseling. I explained with the family tree, where you have, for some families, you had 50% chance that this mother is a carrier, and that means 25% chance that this daughter is a carrier. If you know the mutation, you can check in each part of the family who is at risk. Do they have the mutation or not? Then, of course, it's up to those families to decide how to use that information. They can do pre-diagnosis implantation, or they can do a prenatal diagnosis. That is up to them, but at least you offer them the choice. What's also important to know is that carriers are at risk for developing cardiomyopathy. So patients, of course, can develop cardiomyopathy, and there's a session on heart problems and heart care, but female carriers also are at risk. Not everyone who is a carrier will develop this. The percentages vary between 10% and 50% depending on the literature. But at least it's a risk, and it's a significant risk. So what should be done? In early adulthood, carriers should have a baseline ECG and imaging, and then there should be screening every 3 to 5 years to see whether cardiomyopathy is developing. And if it is, of course, the screening needs to occur quicker, and also interventions should be started. For the patients, knowing the genetic diagnosis means that you can start the care and management. So, well, the whole day is about care. So all these different things you can only do when you have your genetic diagnosis, when you know that the boy has Duchenne. We heard in the previous session all the side effects of corticosteroids. We use them because they slow down disease progression for Duchenne. But for some other muscle diseases, actually they make the matters worse. So you want to be sure that someone has Duchenne before prescribing this. You want to exclude that they have another muscle disease where actually doing prednisone is the worst thing you can do. So again, you need that, and once you have the genetic diagnosis, you can start this. And then finally, there's also mutation-specific therapies. So the stop mutation, the one mutation that changes the code for an amino acid into the you can stop the protein's complete signal. There's a therapy for that called Ataluren, Translarna. It's available in the UK, but of course, it's only given, because it's expensive, it's only given to patients that have that specific type of mutation. So you need to know that the patient has that mutation. Also, there's exon skipping in development, and again, whether patients are eligible, which exon to skip, depends on the mutation. So again, there also, it's important to know the exact mutation. So then, in my final slide, how do we check for mutations? Just a rewrap. We've gone over this, but I think it's important, so we'll do it once more. So the first check is, on DNA, is there a large deletion or a large duplication? If so, check the genetic code. Do we expect Duchenne or do we expect Becker? And if we know it's Duchenne or Becker, you can start the counseling, you can start the care, and you can start checking. Is this patient eligible for mutation-specific therapies? Are there mutation-specific therapy trials happening? And check that. If there is no large deletion or duplication, you go and check for small mutations. Again, if the small mutation is there, check for the genetic code and, well, start the counseling, start the care, see whether it's a nonsense mutation, so one of these stop mutations, and if so, start Ataluren. If there's not a small mutation, then, and only then, you do a biopsy. And check, is there dystrophin, yes or no? If there's no dystrophin, Duchenne is confirmed. But you don't know the mutation, and you can try and look for it using the material that's left over from the biopsy. But the problem here is that if you don't find the mutation, you can confirm Duchenne. You can start the care, but you cannot do any mutation-specific therapies because you don't know the mutation. You can also not do genetic counseling because if you don't have the mutation, you don't know whether the mother is a carrier because you don't know what to look for. So this is, fortunately, this doesn't happen a lot, but it does happen in some cases. It's still important then to confirm Duchenne. So at least you can start with the care. But the other two things, the counseling and the mutation-specific therapy that ideally you also want to initiate, you cannot do. So that was my last slide. If there's questions, I'm of course happy to answer them. I'll be here until about 3:30, so feel free to also ask me questions during breaks if you prefer that. But happy to answer questions now as well, if you have them. Well, they say early adulthood, and they're not very prescriptive because there's differences in how countries look at it. So there's countries where you're actually not allowed to check if someone is a carrier before a certain age. So, well, if you don't know you're a carrier before you're 21, then how can you start at an earlier age? I think early adulthood, so 18, 19, 20, if they develop cardiomyopathy, they will not develop it at the age that Duchenne patients develop it. They will develop it generally in their later in life. But having a baseline is important because then you can see progression. Are patients getting worse? And I mean, everyone's different. So early adulthood, but they don't specify a specific age.
Thank you.
Yeah, so manifesting carriers are carriers that experience muscle problems. And this can differ from muscle cramps. Some patients have, or some carriers only have elevated levels of serum creatine kinase. So again, a muscle damage marker. They don't really experience pain or cramps or fatigue. They just have that, and still they're called manifesting carriers. I think it also matters, I mean, if I overdo things, I also get muscle cramp. So, but I'm not a carrier. So I think this is a bit challenging. However, whether you get the cardiac problems, the cardiomyopathy as a carrier, does not relate to whether you're a manifesting carrier or not. So this is not something that if you think, well, but I don't have any other muscle problems, so I will not be at risk. This is regardless of whether you experience muscle problems or not. So really all female carriers should be aware of this risk and should check. It doesn't happen in the majority of carriers, so that's good. But still, if you're at risk and there's medication that can help protect you, then it's better to screen and intervene if needed than to not do it. So I think, so what's done now is, of course, you check the DNA of the blood, mainly. And then you see whether that mutation is in the DNA of the blood of the mother, yes or no. And if it is in the DNA of the blood of the mother, then it's assumed that it's everywhere. The problem is slightly more complicated than that, because in fact, carriers have dystrophin in 50% of their cells. So women have 2 X chromosomes, men have only 1, and it's not viable to have 2 active X chromosomes. So what happens in each cell, one of the 2 X chromosomes is inactivated. So that means that women have 50% of the cells expressing dystrophin and 50% of the cells not expressing dystrophin. You will not see, I mean, if you look at the blood DNA, you will just see that there is a mutation. What you do not know is how that inactivation happened in the skeletal muscle and in heart. And the thing is, it is a random process. So when the embryo is about 100 or 200 cell stage, each of these cells determines, will I inactivate the X chromosome that I got from my mother or the one that I got from my father? And then, from that point, they will all inherit this. And generally, this happens on a 50-50. I mean, it's just flipping a coin 200 times. Generally, it will be 100 times head, 100 times tails. But, of course, sometimes things go wrong. Or, well, not wrong, they're just skewed. So it's possible that this is, for instance, 20% of the times you get the healthy X chromosome that's active, and 80% of the time you get the mutated one that's active. That means that these mothers, these carriers, then have 20% dystrophin expression in their muscle and in their heart. And these are things you don't see in blood. So the only way to really see this is if you take a skeletal muscle biopsy or a heart biopsy, which generally we do not really like to do. So this makes things more complicated, and this probably also explains, because the percentage of dystrophin positive cells may differ in different tissues. So even if you do a skeletal muscle biopsy, you see 50% as expected. That doesn't mean that in heart it's also 50%. And this probably relates to your question. This probably explains why even if you're muscle-wise you're okay, you have no problems, still you can have problems in heart. And I'm not sure whether in the near future we will find a way to really know from an early stage, like, you are at risk for developing cardiomyopathy and you are not. But I think until we do, we just need to screen everyone. And screening every 3 to 5 years, I think, is not that cumbersome. So I think that's probably a better solution than a cardiac biopsy. Well, I think, getting a bit philosophical here, I think, but a mutation has a definition, and I know that it may have some negative connotations, but in the genetic field, a mutation is qualified as something that disrupts the function of a gene, and therefore the function of a protein. There's also a lot of variation. So, I mean, people have blue eyes, people have brown eyes. That is variation. I mean, but if there is a change in a gene that causes a protein not to be functional, that is what we call a mutation. And if that has negative connotations, we can try and find other words. But yeah, this is how it's defined in genetics. And then I think it's not the fault of the geneticist that then the rest of the world gives it a negative connotation. So I think what's good to bear in mind is that we all carry mutations in genes. And well, some of them may be more important than others. All of us carry mutations. So it's not so much that if you have a mutation and it just happens to be in dystrophin that makes you a lesser person. Everyone in this room has mutations. I think that I want to make clear, so including me. If you're a carrier, you get a son, there's each pregnancy, there is a 50% chance that that son has Duchenne and a 50% chance that he does not have Duchenne. And then it's just the roll of the dice where you can have these weird coin flips where you have heads. And I know that there's families that have 5 sons with Duchenne where you think, well, statistically that shouldn't happen, but it does happen. So it is chance, or in that case, bad luck. I mean, the opposite happens, of course, as well, fortunately, where there's people that have only 1 son with Duchenne and 5 or 6 without. Well, that also, I mean, is not what you would expect. So it really is, yeah. So, but the thing is that you think that if you had 5 pregnancies and all were Duchenne, that the 6th one, you have less chance than that 50%, but that's not the case. If you had 5 with Duchenne, the 6th one, you again have a 50-50 chance of it being Duchenne or not.
There's no other biological factors or DNA that we know about?
No, not that we know about. No. But I mean, there's even said, so I know one story from someone in China. So the mother was a carrier, they knew the mutation, and in China, of course, you can have only 1 child. But if your child has Duchenne, you can ask for dispensation, and then you can have a 2nd child. But then they said, well, but we want to do prenatal screening. We want to make sure that this child does not have the mutation. And they did, and it was a boy, and he did not have the mutation. Then he was born, and the mother said, well, he looks like his brother. He looks like he has Duchenne. I mean, it shouldn't be possible because we checked, but he looks like he has Duchenne. And then it turned out that her other X chromosomes, it was a germline mutation. So part of her other X chromosomes had another mutation. So she got 2 sons with different mutations. And also there you think, well, that's, I mean, how many bad luck can you have? But it happens, unfortunately.
Any further questions? Thank you, Annemieke. Thank you very much.
Thank you.